So I'm Dr. Wedman, and we're going to be discussing Birads today, particularly as pertains to mammography, and we'll touch on sonography. So Birads came about at the same time that mammography screening was being implemented as a new national screening program. And so this all started in about the 1980s. And the American College of Radiology convened a group of radiologists and physicists, as well as an FDA representative, to help us figure out best way to maintain good image quality, um, control for appropriate radiation dose, and discuss the type of machinery that needed to be used, and multiple other things that eventually ended up being codified in the Mammography Quality Standard Act in 1992, or the MQSA. And it also provided a pathway for us to have facilities acquire accreditation to help us maintain quality and consistency across facilities, across geography, and over time. The image interpretation portion of this, they also realized, was also important. And how do we report those imaging findings? So um, they developed something called the Breast Imaging Reporting and Data System, or BIRADS, and it provides a framework which allows radiologists to standardize reporting of this new national screening program. You'll hear us refer to sometimes the BIRADS Atlas and the BIRADS Lexicon. We do tend to use these words interchangeably, although the Atlas itself refers to the book, the large publication that provides all the very detailed information that goes into this system that was developed. And the lexicon itself specifically refers to the vocabulary that we use in daily practice, that vocabulary that helps us distinguish between benign and malignant lesions, and then also to appropriately, effectively communicate a level of suspicion based upon those imaging findings. So the system provides guidance on the type of appropriate imaging that's also provided. Further guidance is also included with the ACR appropriateness criteria, which is a separate publication, but also can be used in conjunction with BIRADS. It also helps the accrediting bodies, which include the FDA and the ACR, and through use of the framework also set up by the MQSA. And as we discussed previously, it provides a vocabulary which helps us communicate and establish a level of suspicion. It also gives us a framework for appropriate reporting structure so that across the country, mammography reports will have a similar structure that primarily includes the assessment categories. And those assessment categories are BIRADS 0 through 6, and what those categories mean as far as subsequent management. And it was this management component that really further increased the clinical value of diagnostic radiology, which at that point in time, diagnostic radiology really focused on imaging findings. But referring doctors really wanted to know, what do those imaging findings mean? What's the next step I need to do? And BIRADS really allowed that to become more of a solidified part of the radiology report. In addition to helping us find a level of suspicion and communicate what that level of suspicion is and what the subsequent management would be, BIRADS allowed for a framework for data collection because there was now standardized reporting and a standardized coding system with BIRADS 0 through 6 that was established. Information could be queried and could be compared, and really helped for making sure that we maintain quality control. Um, and lastly, Pirates is a living document. There have been multiple updates and it continues to be updated. The most recent version of Pirates that we're using is the fifth edition, which was published in 2014. A new one has been in development for quite some time. And honestly, I don't know when that will be published because we kind of hear it's always going to be published and it never is. But certainly it's not an easy feat to update. However, there were supplements that were added with the use of digital breast tomosynthesis now being commonplace, as well as contrast mammography. Interestingly enough, in the update, they state that the preferred terminology for tomosynthesis is DBT, or digital breast tomosynthesis, or we can also refer to it as TOMO. Um, 3D mammography is not a preferred term because it is not technically a 3D examination, so they discourage the use of 3D mammography. So it was very kind of them. If you've ever seen a full printed version of the Birads Atlas, it's very thick, very detailed. That they came up with a quick reference card that you can access from acr.org/Birads, and you can print this up on your local computer. We do have this posted in several of the reading rooms. And it's again a quick reference for sonography and mammography, and on the back side for MRI. It really breaks down the more salient pieces of the atlas. If you're in a situation where you just can't remember what's the correct phraseology, you can look at that quick reference card. So we're going to discuss BIRAs based upon their recommendation for report structure. And again, it's pretty common now, the fact that we're discussing report structure is a little bit strange because we're used to this now. But again, at one point in time, it was a novel idea. And they do recommend that reports have an indication. Is this a screening examination or a diagnostic examination? Were there comparison studies? And in the technique portion, it's not just what type of study it was, but is the imaging technique um, appropriate or adequate? So we also have to evaluate that technique. Across all breast imaging modalities, breast composition has become something that's very important. In mammography, we discuss density. In ultrasound, we do echo texture. And in MRI, we often discuss background parenchymal enhancement in addition to density. Um, Probably the most important piece of the report structure, though, comes down to the imaging findings. It's really in this area that we're going to develop our level of suspicion. And we get to our what we call the impression portion of the report. It's our assessment, our overall BIRADS assessment. What category number are we going to assign to that study based upon our level of suspicion? And then what does the radiologist recommend we do with that information? What are they going to tell their referrers? What does all of this information ultimately mean? What is actionable on that report? So let's discuss it primarily with mammography, as this is where BIRADS was first developed. And we'll see that across different imaging modalities, pathology has similar imaging features. So we can really use mammography as our baseline here. All right, so quick review of these. This is a lot of information, so we're not going to really go into much detail. You're going to have other lectures that are a little bit more detailed in each one of these topics. But for mammo technique, particularly in a screening mammogram, generally we do CC and MLO views. The CC craniocaudal projection is basically at a 0-degree angle, and the medial lateral oblique can be between 45 to 60 degrees. And you see here on the MLO view, you get a view, include a portion of the pectoral muscle. They decided to come up with this MLO view after looking at different breast imaging positions, and they felt that the MLO view allows for the greatest visualization of most breast tissue. It's the best position for seeing the most breast tissue in a single image. So is this screening study technically adequate when I look at these CC and MLO views? Is there enough tissue? On the MLO view, do I see the pectoral muscle to the level of the nipple? If I look at the posterior nipple line drawn from the nipple to a 90-degree angle at the muscle, comparing it to the posterior nipple line on the CC projection, is the distance measured between these two lines within 1 centimeter of each other? Do I see the inframammary fold on the MLO view? Is there motion blur on either of these images? Motion or blur is very important not to be there because it can really change whether or not we're able to see fine calcifications. And is the nipple in profile in at least one view? But I will tell you, us radiologists really want to see that nipple in profile in both views. It's very helpful when you're trying to localize an imaging abnormality on mammography. So we've evaluated a technique. Now we're going to discuss breast density or tissue composition. And why is it important? Is primarily because it helps us understand the native environment, that patient's anatomy in which pathology can develop. And if you refer to that quick reference card here, you're going to see breast composition is up at the top portion. So you can always refer to it if you get confused or you forget things over time. So, what is density as pertains to mammography? It is a true mammographic definition, and it discusses how the breast looks on a mammogram, or more technically, what is the degree of X ray attenuation of the breast tissue. And it lets us know the ratio of glandular tissue, which appears white, to the ratio of fatty tissue, which is dark. So the more white a breast appears on the mammogram, it means there's more glandular tissue present relative to fatty tissue, and that means that the breast is more dense. A dense breast, it's not a clinical definition. It has nothing really to do with the way the breast feels on physical examination. Many patients will say they have dense breasts because their doctor told them when they had their examination, their clinical examination, but it doesn't always correlate. So density in the true sense of the word is a mammographic definition. And there are four breast density categories, and they are denoted A, B, C, and D, with those categories being entirely fatty, scattered fibroglandular, heterogeneously dense, and extremely dense breasts. And historically, these were discussed in quartiles, so 25th, 50th, 75th, and greater than 75% glandular tissue. Now they're really referred to as groups A, B, C, and D. So you can imagine as the breast gets more dense, it's going to be harder for you to see a pathology in the extremely dense breast, in part because pathology tends to be dense as well. So when you superimpose something white upon something white, it can be harder for us to distinguish with the human eye. Interestingly enough, you can have instances where a patient will have dense tissue that's relatively localized to one part of the breast as opposed to throughout the breast. So, whereas the overall composition of this breast might be less than 50% fibroglandular tissue, you might say, you know what, this tissue is pretty dense. So, the Birads lexicon does allow us to assign a higher overall density category if there is a relative patch of dense tissue. But you do need to be cautious that you are in fact looking at fibroglandular tissue and not pathology itself. So why do we care? As we already touched upon this, dense tissue is white. Cancers that are dense are white. So white on white is just harder for us to see. There are also several studies out there that suggest that women with more dense tissue also have a higher lifetime risk of developing breast cancer, although this is controversial. More importantly, however, it helps us on the interpretation side because it um, establishes a sense as to what the native environment is in which that pathology can develop. Is the patient's native anatomy helpful for us in determining whether or not there's a cancer, or is it working against us? So we're going to move now on to specific imaging findings in mammography. And again, those specific imaging findings are the meat of Birads lexicon, and it helps us determine a level of suspicion. It helps us interpret those images. So those imaging findings are in the rest of this column for mammography, and the first imaging finding we're discuss is masses. And masses can be described based upon three main groups or characteristics, and that's shape, margin, and density. Within the shape group, they discuss oval, round, and irregular findings. And as we go from oval, round to irregular, um, the likelihood of malignancy increases. And so we're going to get more into this alphabet soup of imaging findings, and I find that mnemonics are very helpful to helping me remember stuff. So if we take shape, oval, round, and irregular, SORI, we get the word sorry, which in other words is Canadian for sorry. And thank you to our friendly neighbors to the north. If anyone was ever a fan of Anne of Green Gables, they'll remember that Gilbert had to apologize to Anne multiple times. I don't know if anyone has seen this TV show, but you should if you haven't. And here's our friend Gilbert having to apologize over and over again.
Sorry, I'm sorry. Sorry. I'm sorry. 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 Sorry.
So he had to shape oval, round, and irregular a lot.
Sorry.
Okay, so now let's go on to margin. Margin can be classified into five subcategories. The first being circumscribed, or at least 75% of the edge is well defined, and it is generally a benign finding. We go on to obscured margin, and greater than 25% of that obscured margin is not seen, it is obscured. It implies likely circumscribed margin, but you can't be, you're not entirely sure of that. It's not definite. So again, we see increasing likelihood of cancer as we go down this list. Microlobulated margin is usually suspicious, as well as indistinct margins also suspicious. It raises concern for an infiltrative process. And of course, spiculated margin is also suspicious for underlying malignancy, although it can be seen in the setting of surgical scars and traumatic scars. So here we have circumscribed. We can see that it is well defined and sharply marginated. Obscured, more than 25% of this finding is not well seen. Microlobulated, very, very small undulations with sharp angles. Indistinct just looks like it's been smudged. And of course, spiculated looks like a very angry sunshine. And as we move down this list, so does the likelihood of malignancy increase. So how do we remember all of this? If we take our letters here, COMICINSP, we get some comic inspiration to help us remember those margins: circumscribed, oval, microlobulated, indistinct, and spiculated. Thanks, Andy Samberg. Okay, now let's move on to density. Density of the mass, as we see relative to a density of glandular tissue, is a helpful imaging finding. And again, as we also discussed previously, density is related to the attenuation of X-rays by an imaging finding, in this case, pathology, a lesion. And most cancers are of equal or high density, and generally fat-containing lesions are usually benign. They are rarely cancer, but they still can be. And here we have example of high equal low and fat containing lesions. Here we have high density. It's almost completely white. You can imagine if you have white dense tissue, that would be very hard to perceive this abnormality. Equal density, it's isodense to a neighboring glandular tissue. Low density, it is, and then here we have fat containing. This arrow points to a benign bulky calcification, but you can see here this fat is similar to the background fat in the breast of the breast, and is pretty much and is radiolucent. As we move in this direction, we see again there is a trend to help us know that there is an increasing likelihood of malignancy. And we take our letters H, E, L, and F. What can we come up with? So do you remember your density categories? You know, hell if I know. Why are you keep pressuring me so much, Dr. Wedmed? But we have high, equal, low, and fatty density for these imaging findings. Okay, so we've covered masses, and now we're going to go on to calcifications and their descriptors that help us arrive at a level of suspicion on mammography. And calcifications are primarily described by their morphology and their distribution. And in the morphology group, there are typically benign calcifications and suspicious calcifications. And we go to the typically benign list, and there's a lot. And we don't really need to get too detailed about them, but you can have benign appearing, lucent centered skin calcifications. You have vascular calcifications that have their tram track appearance. I think it looks like someone took a drinking straw and coated the inside of it with powdered sugar. We have popcorn calcifications with a benign degenerating fibroadenoma. Secretory calcifications are large rod-like calcifications. Eggshell calcifications that we can see with an oil cyst. A nice homogeneous rounded calcification. Here, dystrophic calcifications in the setting of fat necrosis in the surgical bed. This is a nice example of benign layering milk of calcium. You can see it has that teacup sign. And suture calcifications, if you look closely at this particular calcification, you can see that this is a knotted off suture. So let's go and focus more on the suspicious calcifications. You know, if you see those benign type calcifications, you'll learn quickly what they are. You don't need to really memorize words or descriptive terms. Um, but with suspicious calcifications, it's a little bit more helpful to concentrate on the verbiage. Amorphous calcifications are fine and powdery and oftentimes very difficult to see on mammography, and they don't really project well on this screen. But again, they are suspicious, and it's difficult to describe their shape. It looks more like powder. Coarse heterogeneous calcifications are really disorganized. They are areas of dense, almost dystrophic appearing calcifications. Sometimes I have a hard time distinguishing between coarse heterogeneous and dystrophic, or sometimes developing popcorn calcifications. If there's any question, we can sample it. Thankfully, tomographic biopsy of calcifications is a minimally invasive procedure, but coarse heterogeneous is suspicious, particularly if you have a single developing group of coarse calcifications in the breast. Fine pleomorphic calcifications are different shapes and sizes as well as different densities. These are suspicious. And you get to fine linear branching. You can see here you have these calcifications that look like they're forming lines. And if you follow closely, there's a very faint line. And how are these different, though, from benign secretory rod-like calcifications? Well, they are because they tend to branch, and if you look closely at them, their margins sometimes tend to be a little bit more irregular, whereas secretory calcifications usually have a nice, smoothly marginated border. So, amorphous, coarse, heterogeneous, fine, pleomorphic, and fine linear branching. And we take our letters to help us remember that. Amorphous, coarse, heterogeneous, fine, pleomorphic, fine, linear branching, and we get a cheesy, fresh pizza from Lebrano's. Okay. All right. So distribution. We've discussed morphology, and now we're moving on to distribution. And distribution is described as being diffuse, regional, segmental, grouped, or linear. And generally, diffuse calcifications are associated with benign type calcifications, and these other types of calcifications tend to raise your level of suspicion. So, distribution is diffuse, regional, segmental, grouped, and linear. All right, so how are we going to remember this? Well, we've all been in this situation. You go ahead and you knock on the door of the reading room, you ask the radiologist a question, and you know, the disturbed doctors go loco. Disturbed doctors go loco. Okay. Masses calcifications now. Let's move on to architectural distortion. Architectural distortion is something that really drives us nuts on imaging. Sometimes it can be so extremely subtle. And I like to think of pseudo-architectural distortion as appearing something similar to pickup sticks, where all of these nice normal lines are superimposed upon each other, and we get the sense that there's distortion, but it can actually just be overlapping normal Cooper's ligaments. And it can really fake us out sometimes. I consider this to be more similar to what true architectural distortion is. You have all of these nice threads or look like they're going towards a center point. As you can see here in this really nice example, you see that there's all of these lines are going to a center point, and they're coming to that central portion and they are not crossing over. They're stopping right there in the middle. They are not overlapping. And you can see architectural distortion in the setting of something that was done to the breast, as in trauma or surgery, or in the setting of something that has occurred within the breast, fibrosis, sclerosing adenosis, radial scars or radiosclerosing lesions, and of course, in the setting of cancer, as was in this case, and this is one of our patients. Um, the other imaging findings, lymph nodes, skin lesions, solitary dilated duct, and associated features we won't delve into. There's a lot more to cover, but again, you can refer to your Birads atlas if you want more information. Um, I apologize. So let's go back. We are going to discuss asymmetries. So asymmetry is a non-committal term. It's a general term for a density that does not really have a mass-like quality. It's not truly measurable. Um, and there are four types of asymmetries, and the first subtype is called asymmetry. So it's an asymmetry is something that is seen only in one view. And you can use these words to kind of determine just by reading the report what type of imaging the radiologist wants. So if you see on a screening mammogram, the doctor says something like there is a possible right CC asymmetry, you know you're going to do the protocol for a one view finding. A focal asymmetry is seen in two views. So you're going to do an imaging protocol and diagnostic workup for a two-view finding. It'll be seen in a CC and MLO view or a CC and XCCL view. A developing asymmetry is an asymmetry that's been there before, but over time it's increasing in size and or increasing in density. I really caution against using the word developing. Usually we'll just say there is a possible asymmetry on the MLO view, for example. A global asymmetry is something that's seen in two views, but it involves more than one quadrant, and those are generally benign. So again, developing asymmetry is a word that I will not use in the report. It is not really helpful. If someone's going to inherit that BIRADS Category 0 callback study, they should be comparing priors anyways. That interpreting radiologist at the time of the diagnostic study will realize that that asymmetry is developing. Again, it's an instance in which the BIRADS lexicon is helpful to us for establishing a level of suspicion, but we don't necessarily need to use the words in our reports. So here's an example of a developing asymmetry. You can see if at any single time point you only had one of those images, this finding might not catch your eye. Here, certainly it is increasing in density over time, but if this were the patient's baseline mammogram, this asymmetry doesn't really look any different than these other areas of normal tissue. So this just is a way to highlight the importance of having prior studies. An example of a global asymmetry, here we are in this area involves both the superior and inferior breast, and on the CC projection, it involves the lateral and medial halves of the breast. If you looked at this individually, this stuff just looks like normal heterogeneously dense tissue, but it's asymmetric to the contralateral side. Is this pathology? No, generally this is just asymmetric development of breast tissue and usually benign. Again, more than one quadrant and seen in two views. Okay, so I apologize. These other findings, lymph nodes, skin lesions, etc., they're in the lower part of the quick reference guide, and there's much more detailed information in the BIRADS Atlas itself. So for mammography, a quick review. Masses, shape oval, round, irregular. Margins are circumscribed, obscured, microlobulated, indistinct, and spiculated, and density is high, equal, low, and fatty. Calcifications are described based upon their morphology and distribution. And if we get a cheesy fresh pizza from Lebrano's, we know that those calcifications can be amorphous, coarse, heterogeneous, fine, pleomorphic, and fine linear branching. And if we disturb those doctors and they go loco, we know that our distribution can be diffuse, regional, segmental, grouped, and linear. Again, all of these words and their associated imaging findings are helping us arrive at a level of suspicion. Let's touch briefly on ultrasound. Ultrasound again has that same reporting structure. We're going to evaluate the technique of that ultrasound image. Is the imaging quality adequate? Do we have good transducer orientation, good skin contact? Is there appropriate compression? And it's very important, I think, in breast imaging to vary the degree of compression. If you're looking for a cyst and you're using a lot of compression, you can really compress that cyst down and not see it well. On the flip side, if you're not using enough compression, you really don't get a sense as to whether or not there's a true persistent hypoechoic suspicious mass there. So varying degrees of compression throughout your examination is helpful. You want to make sure that your frequency range is in a good is good. Ideally, you should be using high frequency linear probe at 15 megahertz or 12 megahertz. You can lower um, your megahertz if you need to penetrate a larger breast or deeper tissue. Ideally, in our images, we do want to see the pectoral muscle. It gives us a sense as to depth. You want to make sure your focal zone is at the appropriate position, that your gain is appropriate, and your image labeling is also very important. I think it's important if you have a focal lesion and you center that lesion on the transducer, your annotation should then be based upon where that center point is on the transducer. So instead of if you have a 2 centimeter abnormality, instead of saying this finding is at 2 o'clock, 5 to 6 centimeters from the nipple. What I like to say instead is the center of that lesion is at this specific location. You really don't want to have this annotation where you are describing a focal finding and it has um, 2 to 4 o'clock, 5 to 7 o'clock. We'll use that type of annotation if we want to document an area that we scanned that was negative. And again, the depth of a lesion is very important. You should correlate that with the finding on mammography. You don't want to see something in the superficial part of the breast on the ultrasound and assume it's the same finding on mammogram when the finding on the mammogram is at posterior depth. Okay, we come back, we're revisiting breast composition. Again, it gives us a sense as to the native environment. I honestly tend not to use these descriptors in my reports for sonography, but they do have appropriate BIRADS verbiage for that. The three types of breast composition are homogeneous background echo texture of fatty type, homogeneous background echo texture of fibroglandular type, and heterogeneous background echo texture. So here's their provided imaging examples. And here you can see there's homogeneous distribution of the tissue, but it is predominantly fatty. Here is homogeneous distribution of the breast tissue, but it is predominantly fibroglandular. And here we have heterogeneous distribution of the breast tissue, which you can see to better advantage here on the ultrasound, where there are areas of fatty tissue and areas of glandular tissue. So a heterogeneous distribution of tissue. We'll move on to the imaging findings, which again, we'll discuss our masses calcifications, and we really won't go into detail about the associated features and special cases. But as previously discussed, shape is an important descriptor of masses. For ultrasound, we now also introduce the concept of orientation. We rediscuss the concept of margin, and we add the idea of echo pattern and posterior features. So for shape, look, it's our friend again, oval, round, and irregular. Interestingly, on sonography, the oval mass will allow for up to 3 broad, soft undulations, different from irregularity. But yes, your oval can have broad undulations. And again, also there, as you move to this direction, there is an increasing likelihood of malignancy with irregular masses being the most concerning. Here's our friend, Mr. Sori from Canada. Um, and orientation is broken up into two groups. You can have parallel and anti-parallel, or wide and tall. So for parallel, the long axis defining is parallel to the chest wall. Again, that's our wider than tall lesion. These are more commonly benign, like our friend Kermit the Frog, who's lounging here on his side. He's just having a great old time. He's not causing any problems. Um, when you have an anti-parallel or taller than wide finding, the long axis of the lesion is perpendicular to the chest wall, and there's increased level of suspicion. This guy is standing up. He's got a lot of energy. He's getting into trouble. He's like animal. So yeah, that's how I remember those things. Increased suspicion. Ultrasound masses, again, margin is another important descriptor. And this can really be simplified as being either circumscribed or not. Unlike mammography, when you have a circumscribed finding, and it can be only 75% of the margin is well seen, on ultrasound, you have to see the entirety of that margin, and the entirety of that margin has to be circumscribed to be considered within this group. All of these other ones, already you have you're having an increasing level of suspicion for malignancy. Another interesting thing, not really directly so much discussed in the BIRADS lexicon, but technically, but is super important, is what is your lesion boundary? If you have an abrupt interface between your imaging finding and the surrounding tissue, you're going to be favoring a benign process, unlike the echogenic halo. So here we've already discussed we have an indistinct mass, and that interface, you can see that there is a almost a thick smudgy band of whiteness around it, an echogenic halo that raises your level of suspicion. We'll discuss now the echo pattern as another imaging finding. And again, you can simplify it. They have a lot of nice descriptive terms, but out of all of this echo pattern, only two tend to favor a benign imaging finding, and that's anechoic and hyperechoic. These other imaging findings either increase your level of suspicion or are really non-contributory, meaning they neither increase or decrease your level of suspicion. And interestingly, your reference echo pattern is subcutaneous fat. So this is hyperechoic compared to subcutaneous fat. Okay. Posterior acoustic features can sometimes be helpful. If you have posterior acoustic enhancement, it at least lets you know that the finding is generally homogeneous on the inside, that there's no haphazard cells that are breaking, making it difficult for those sound waves to be transmitted and received. Shadowing, you have to be very important that this is not an artifact, but shadowing raises our level of suspicion as well as the combined pattern. There are areas of shadowing and there's areas of posterior acoustic enhancement. So there's heterogeneous posterior acoustic features. So a little bit more complex, you don't really have that linear progression of increasing level of suspicion. Some of these imaging findings kind of fall into a non-contributory or indeterminate category. So I found this chart to be most helpful. Here, features that favor benignity would be your oval shape, same as mammography. You want it to be parallel or wider than tall, circumscribed margin, an abrupt interface, and anechoic or hyperechoic imaging finding. These other findings, which generally we like to put into the benign category, are actually relatively indeterminate. They're helpful, but we really shouldn't hang our hat on them. So you can still have something malignant that has these imaging features. Calcifications on ultrasound, we generally don't use sonography to evaluate calcifications, but if we see them, we should be able to assess them. If we see it in a mass, they do tend to be hyperechoic foci. Outside of a mass, these are more likely to blend in with the normal Cooper's ligaments. If you're catching something like this in cross section, it can give you a sense that maybe that's a calcification. However, if you do see something that looks like calcifications within the background tissue, you really need to go back and look at your mammogram. And your mammogram will be combined with the interpretation of the ultrasound will help you whether or not you need to determine whether or not you need to consider biopsy. Similarly, if you do see calcifications within a duct on ultrasound, go back and look at that mammogram. You want to see if you can find where those calcifications are, and you may need to consider biopsy. All right, so our associated features and our special cases include things like lymph nodes, they discuss implants, etc. Um, so we've gone through all of these things with ultrasound. Again, the indication and comparison are the same. We evaluated our technique. We've discussed how the native environment or the breast composition is important for establishing a level of hostility to that native environment, how our imaging findings help us arrive at a level of suspicion. And then we need to get to our assessment and management. And here is the a nice chart about of the Birads categories 0 through 6 and what those categories, what those numbers mean. And this terminology needs to be specifically used in our reports. ACR has published BIRADS terminology, but that needs to be cross-referenced with the MQSA terminology, and we need to use the MQSA terminology in our reports. They're very similar, but there's subtle differences in some of the words, and I think it's just due to differences in timing because the MQSA law was passed before the most recent update of BIRADS. All right, we have a screening examination. We should only be assigning BIRADS 0, 1, or 2 to our reports. We do not assign a BIRADS 3 through 6 on a screening examination. Um, Either your 0, need more information, or your 1 and 2, the exam is normal, we'll see the patient in 1 year. And um, it's interesting to highlight that if you look here, BIRADS 3 imaging findings have a less than 2% chance of being cancer. So if you're going to be assigning something a BIRADS 3, you better be pretty sure that it's something benign. I do like to stress to patients that when we give someone a BIRADS category 4, it has a very scary word attached to it that means suspicious. So I stress to them, look, that word suspicious really shouldn't be that scary. It just means that we need to take some action. We need to sample that tissue to get more information. When we use that suspicious category, it means that there is a greater than 2%, but less than 95% chance that we think this is going to be cancer. That's a huge spread. So when I explain to them that there's a 2 to 95% likelihood that this finding is going to be um, cancer, they feel much more comfortable. Certainly, I will tell patients if I'm looking at something that has BIRADS category 5 features. This is, some people consider it controversial, but I tell you far and away, that's really what patients want to know. They want to know what the doctor is seeing at that point in time. They want to be prepared before their biopsy. Um, and I just say, look, I hope I'm wrong, but I am concerned with what I'm seeing. We need to do a biopsy of this finding and we'll take it from there. And sometimes we'll discuss whether or not it's a good idea for them to consider looking at surgeons ahead of time. Okay. So another interesting thing that has come out of BIRADS, if we go back, we look at these assessment and management categories, oftentimes you would assume that each one of these numbers is assigned to a specific word, which means that I have to assign a specific management. However, that's not always the case. So BIRADS does allow for a mismatch or a discordance between the assessment category and the management that goes along with it. And one clinical scenario you can think of is if you have a person presenting with bloody nipple discharge, but their mammogram is absolutely normal, and so is their ultrasound. So the BIRADS category you would assign to that would be a BIRADS 1. It is a completely negative imaging evaluation. But you know, in the instance of bloody nipple discharge, your pre-test probability, your clinical suspicion for underlying malignancy is pretty high. And you want that patient to go see a surgeon. So you're going to put in that management, recommend surgical consultation. You might also put in before the patient sees a surgeon, I want that patient to have a bilateral breast MRI with and without contrast. So in conclusion, BIRADS is a complete system. We mainly discussed the importance of it providing guidance for determining a level of suspicion and then what that subsequent management is. And out of all of that information, it provides an effective way for us to communicate those results to referring physicians. And now that patients have access to their medical records, a way to communicate those results to patients. Um, Interestingly enough, at the time of image interpretation for a screening report, that lexicon can again help us determine a level of suspicion and help us decide whether or not we want to have that patient come back for more information by RAS 0. But we really try to limit in our practice the use of that terminology. We prefer to limit our screening mammograms to the words of possible asymmetry, possible focal asymmetry, possible distortion, and possible calcifications. We really won't describe a possible imaging finding on a screening mammogram as um, there is a possible spiculated mass with calcifications of the upper outer quadrant of the right breast. Get additional imaging evaluation. By using those descriptive words within our screening report, we're already assigning a level of suspicion. And that can really bind the patient to a management level and the interpreting diagnostic doctor that would then inherit that screening mammogram to a level of suspicion that might not be appropriate. So we never want to bind the follow-up diagnostic evaluation to a level of suspicion that has not been appropriately established. BIRAD 0 means we don't have enough information. Now, anecdotally, some of us will definitely see a BIRADS category 5 mass on a screening mammogram. We still assign that as 0, but they need you to hand that to your radiology assistant and make sure that patient gets scheduled for her diagnostic evaluation. When we get to that diagnostic workup in clinical practice, I still tend not to use every descriptive term used within the BIRADS lexicon to describe an imaging abnormality. Primarily because your radiology colleagues and your referrers, they really don't want a long descriptive report. If we use all of that terminology, I've used the BIRADS lexicon to describe the mammographic finding, and now I'm going to describe that finding on ultrasound, and it's going to be an oval, parallel, circumscribed, hypoechoic finding with posterior acoustic enhancement. When you get to read through all that descriptive terminology, there's the chance that the actionable information can be buried. The goal in your report is to be succinct, and you really want to get to the meat of the report, and that is the impression, the assessment category, and what is the appropriate management based upon those imaging findings. Okay, finally, for mammography, we discuss masses, shape, oval, round, irregular. How masses can be also described by their margins, which are circumscribed, oval, microlobulated, indistinct, and spiculated, as well as their density, high, equal, low, and fatty, and how each one of those terms also has an increasing level of suspicion depending upon what those specific imaging features are. Calcifications can be described by their morphology and distribution. And for morphology, we have suspicious calcifications are amorphous, coarse heterogeneous, fine pleomorphic, and fine linear branching. Our distribution is described as being either diffuse, regional, segmental, grouped, or linear. And similar, again, as we discussed, pathology has similar imaging features across imaging modalities. So with ultrasound, our masses, primarily the most common imaging finding that is evaluated on ultrasound is described by its shape, orientation, parallel or antiparallel, its margin, its boundary, does it have an echogenic halo, its echo pattern, and its posterior acoustic features.